Good morning everyone, and welcome to today's panel interview on digital dentistry and the patient experience. I'd like to welcome everyone and thank our panel members for joining us today. Back in 1983, Mervyn Druian became one of the first UK dentists to introduce the practice of porcelain veneers. Since then, Mervyn's cosmetic and aesthetic work has become internationally renowned, and he frequently lectures and teaches around the world and is the international president of the Alpha Omega Society. He has also worked on the X Factor, Sky News, Channel 4 News, the BBC. Mervyn was also the first dentist to be featured in Vogue magazine. I'd also like to welcome Dr. Simon Chard. Simon currently practices in southwest London, focusing primarily on cosmetic and implant dentistry, and in 2015 was voted the best young dentist in the UK. Simon sits on the board of BACD and frequently lectures on CEREC, and has also recently been featured in GQ magazine. Simon, I'd like to start the questions with yourself, if that's okay.
Yeah.
The first question we'd like to ask is CEREC suitable for a primarily implant-focused practice?
Absolutely, I think. The integration with CEREC and implants is something that I'm really excited about at the moment. Combining that with the Sirona CBCT scanners, and you really can integrate digital into every single element of your implant workflow. So if you merge the digital intraoral scan with the CBCT scan, you can use that to provide computer-guided surgery and then fabricate a stent, either using your CEREC milling unit in surgery or send it out and have a larger surgical stent fabricated. The other way that you can bring it in is you can actually fabricate your implant restorations using your CEREC machine. You can do this either chairside or send it off via CEREC Connect to your laboratory. And it's that ability to replicate the soft tissue profile by getting a scan that is what I find really exciting. And you can mill that in a temporary material, milled PMMA or something like that, before converting it into the definitive ceramic restoration, bonded onto a tie base. And you can either do it cement or screw retained. So it really does offer a treatment modality for every type of implant therapy.
And was that transition to doing the implant workflow gradual, or did you start to work with CEREC and CT immediately?
No, it's certainly been gradual. I mean, I've been restoring in the analog fashion for a number of years. Making that transition into the digital, there are some, it is a relatively steep learning curve, but if you get good training on it and you learn from the right people, actually it becomes so much easier, and the patients really respond well to it because they're getting their implants shouldn't be done quickly and they're not done quickly, but if you can shorten elements of the workflow for the patient by, for example, delivering the definitive restoration on the same day instead of doing it over a 2 or 3 week period, then that's fantastic for the patient, and it's also economical for you because the componentry is considerably less expensive than that outsourcing it if you're doing it chairside.
Wonderful. Great, thank you. Mervyn, I'll move to yourself now, if that's okay. You're an experienced Trios user. Would you tell us, please, how easy is it to use Trios and how accurate do you find the scans work for you?
Obviously, with any of the new technology, there's a learning curve. But once you've learned, it's a terrific piece of equipment. And it's not that difficult. In fact, my chairside assistant can use it. And when I scan, I don't even look at the screen. It's behind me, and my nurse just fills me in, and it literally takes a minute to scan an arch. It's terrific. But be that as it may, the accuracy is fantastic. I mean, I use a laboratory in New York for veneers, and when they send the work back, I don't even touch them. They just fit perfectly. And that to me is a revelation because, and I've still heard people say, well, you can't cross arches with the scanner and that sort of thing. It's not true. It's wonderful.
And what variation of disciplines are you using the scanner for? Are you using it for orthodontic scans as well, Mervyn?
We haven't started to, but we will. I just wanted to really get totally integrated with it for myself. And we have a young dentist who does the orthodontics in the practice. She's going to start using it. But for the moment, I've used it for crowns, bridges, and veneers, and it's been wonderful.
And the learning curve with it was
yes, I mean, look, I'll be honest with you, it stood there for a couple of months before I dared use it. But then I thought, for the investment, I'm going to have to use it.
Indeed, yeah. Okay, excellent, thank you. Simon, I'll move back to yourself if I may. How do chairside CAD-CAM restorations fare in the long term, do you feel?
Well, John, I mean, CEREC's been around now for 30 odd years, and it's come a long, long way in that time, but there is a lot of evidence supporting the use of these all-ceramic milled CAD-CAM restorations in both the posterior and the anterior zone. One study that I always like to reference when I'm asked about this, because obviously people have concerns, are these restorations going to hold up at the back of the mouth in a parafunctional patient? I, touch wood, haven't had any monolithic Emax restorations fracture on me. Obviously that comes down to your preparations and all of the important things that work in analog dentistry as well. But as I say, one reference that I always come back to is a meta-analysis from Hickel and Manhart. It's quite old now, it's from 2006, but what they showed was that milled CAD-CAM ceramic restorations actually had a lower annual loss rate than those made by a pressed ceramic. And actually they showed that the failure rate was comparable to that of gold, which is the gold standard in the mouth. So that's always what I come back to. It's a very good study, and it really gives me faith that the restorations that I'm providing will last for a very long time.
Excellent, thank you very much. Mervyn, you mentioned about the financial investment, and of course the question that everybody wants to know is what is the return on investment with new digital technology? Do you find the Trios financially viable?
Absolutely. Well, okay, not many people will send their work abroad to be made up, but when I think of what I've spent on Federal Express and the courier companies to now just send it with as a scan, as an email, it's a huge difference. Plus, of course, there's the cost of the material and that sort of thing, and the time. And the remakes, you take an impression, you have a look, this is the analog impression, and you're not happy, so you've got to do it again. And sometimes you've got to do it a third time, it becomes very embarrassing. Whereas with a scan, if it's not 100%, you just go back to that area, rescan it, and it's great. And then the remakes are virtually minimal, which saves a huge expense. So it is definitely viable.
It's the hidden costs that you don't have anymore, isn't it?
Yeah, absolutely.
And you've been in private practice for many years, but obviously introduced digital dentistry more recently. What impact patient focus do you feel that's had at a patient level? What has been the response from patients?
It is amazing. Firstly, I'm not one of the youngest dentists in London. Secondly, when patients come in and see that we're embracing this new technology, it absolutely overwhelms them. It's because it is so new, and it's such wonderful technology. And just as an aside, the Trios is just so beautifully designed.
So my question back to yourself, Mervyn, based on that, because you're an experienced user, what's the next big thing in digital dentistry, do you feel?
I don't know. I really don't know. I'm barely trying to keep up.
It's a fast-moving curve, isn't it? For sure.
I think 3D printers are really going to have a big impact on digital dentistry moving forward. Just the low price of them makes them so realistic, even for dentists. I mean, you look at something like the Form Labs, and it's just a fraction of the cost that we're investing in our intraoral scanners. And there's so many applications for it. Digital wax-ups and making your own surgical guides. It really does, it completes the digital picture as far as I'm concerned. And they're getting very, very accurate now as well, even for crown and bridge, down to 50 microns, very, very accurate.
So we'll see a lot of clinicians here at the symposium who haven't yet invested in digital technology and are looking to do that. A question really to both of you, Mervyn, perhaps first yourself. What are the pitfalls to avoid? And if you could go back to the start of the journey, what would be something that clinicians could look to avoid any problems they may encounter?
You need to deal with a company that's got a really good backup system, that are there to hold your hand at the beginning, that are there to answer your phone calls, that you don't just phone and get an answer phone. And I'll be honest with you, your company's been terrific. I mean, Chard has been brilliant.
That's good, thank you. Simon, yourself? Same question?
Yeah, from my point of view, it's training. I know when I was first given my CEREC unit, I came straight out of VT, I was given the Omnicam and told, here you go, this is what you're using for your crown and bridge. And that led to a lot of stressful afternoons for me when I'd promised the patient a single visit crown and not been able to deliver it for them. And that was nothing to do with the computer or how well it works, as I know now, but it was more to do with the fact that I hadn't had the appropriate training. So even from an introductory level, you can make your way through it without any training, but you'll make your life so much easier if you get the proper training right from the start. And within Henry Schein, now we're getting to the point where we do have a lovely pathway for new users to make their way to an advanced level, which is really great.
Yeah, I think we all agree education is an absolute must on the support level, so that's good to hear. Please.
Can I just add, and I'm not sure if it's relevant for this, but I'm a governor of a dental school in Israel. They are not even teaching the students analog impressions. They're going straight into digital.
Really?
CEREC have been amazing the way they've set them up. And they'll qualify as digital dentists.
Yeah, that's the future, isn't it?
I asked Mervyn a question about we've heard a lot, or we will hear a lot about emotive dentistry and patient-centered dentistry. And Simon, obviously you've been in practice less years than Mervyn. The impact on your patients and as you build the practice with digital dentistry, has that been significant?
Yeah, I mean, really just mirroring what Mervyn said, it's been amazing. I always come back to the fact that I've never had a patient get excited about having an analog silicone impression before, but every single day in my practice, we have our milling unit in the waiting room in a lovely box, custom-made display box, and all of the patients get so excited about it. Those that are having their restorations made chairside on the same day, they're all on FaceTime to their families saying, look at my crown being made. They get really genuinely excited about it, and anything that makes patients excited about dentistry can only be a good thing. Especially the engineers and those sort of people, they go crazy for it.
Yeah. So is it fair to say patients come to the practice much better self-educated these days through?
Absolutely.
Definitely.
Oh, yes.
I'm sure that poses opportunities and challenges to you.
It does, of course. But it's always good to have an educated patient.
That's good stuff. Do many laboratories, I know you said you use a lab in New York, Mervyn, but do you find many laboratories accept Trios files or STL type files now?
The ones, yes, I use local ones as well, and they do accept the Trios scans. And having just been to the dental show in Cologne, the laboratories were absolutely queuing around the Trios stand because there's some new technology that's out for the labs.
And just coming back to CEREC and yourself, Simon, what percentage of work would you mill in-house and are you sending out to labs? Is there a mix you work to?
Well, I mean, any single posterior unit's always going to be made chairside with the CEREC for me.
Yeah.
When we move into the anterior zone, I am comfortable doing a 10-unit veneer case using my CEREC as long as I've had a wax-up fabricated either digital or analog before. Yeah. When the teeth are particularly characterized and you're having to match, for example, a single central, but a very characterized single central with lots of translucency and so on, sometimes, and depending on the patient, of course, that's when I will go for I'll send it off to my laboratory, but it's very, very simple to do. It's just a click of a button for CEREC Connect and it's fired directly to my technician. And as Mervyn says, he can then view that in real time with the patient still there and confirm that he's happy with my digital impression. And then I can have confidence that I'm not going to have the technician call me up and say, Simon, your impression wasn't good enough, and then I have to get the patient back in again because that doesn't happen for us anymore. We don't need to worry about that anymore.
Embarrassing.
Yeah, exactly.
Yeah. Gentlemen, it's been a wonderful insight as experienced users and with two different technologies with Trios and CEREC. So thank you very much for your time, and I hope the panel have enjoyed it.
Thank you.